Welcome to this webinar brought to you by SBK Healthcare and supported by Missie, Tumor, Onbekend and Sarah Jennifer Knott Foundation. The webinar is part of the World Cup Awareness Week, and further information can be found at www.worldcupawareness.org. To find out more about further educational webinars and online forums, please do visit our website www.sbk-healthcare.co.uk. In this webinar, you'll be hearing from Professor Penelope Schofield, who is a Professor of Health Psychology at Iverson Health Innovation Research Institute and Peter MacCallum Cancer Centre in Australia. She'll be joined by Alison Taylor, Nurse Consultant, Acute Oncology and Cancer of the Unknown Primary Lead at Clatterbridge Cancer Centre in the UK. They'll be presenting on Uncertainty of the Cancer of Unknown Primary Diagnosis.
Thank you, Sarah. I'm delighted to be here today to welcome you all to our final webinar in the series. As Sarah said, I'm the director of the Sarah Jennifer Knott Foundation, an Irish-based charity based solely on research, education and awareness into cancer of unknown primary. I suppose how we got to World Cup Awareness Week is we were inspired by the work of John Simons in the Cup Foundation, Joe's Friends, a UK charity which has really paved the way for Cup patients throughout the world. Together with the founder of Missie, Tumor, Onbekend, Juanita Minard, we came up with this awareness week to kind of match John's awareness week in the UK. The aim of our week is to raise awareness of cancer of unknown primary and to learn from innovations in countries leading the way in care and support for patients with CUP. We have a website, www.worldcupawareness.org, for all information regarding cancer of unknown primary, and a lot of it is signposted to John's website, cupfoundjoe.org, which has a huge amount of information for everything to do with cancer of unknown primary and all the latest research trials and research papers and everything that we hope to be able for patients and families and healthcare professionals to access the information for. I'd like to extend a warm welcome to everyone joining us today. For the final webinar, we have people, I think, over 191 registrations from all over the world. So we're delighted that it is a world event. Today, in our final one, we're focusing on the uncertainty of cancer of unknown primary diagnosis. And we're delighted to have Professor Penelope Schofield from Melbourne, Australia, and nurse consultant Alison Taylor from England, which is fantastic to share their experiences for patients dealing with this diagnosis. I suppose our theme for the week has been the patient journey, and we've hoped to identify challenges and opportunities for cancer of unknown primary patients, their families, healthcare professionals and researchers, and hopefully we can kind of make a kind of a community so that we can all share our information. I'd like to take this opportunity to say a special thank you to our World Cup Awareness Week sponsors, Roche, and to our supporters, FT3, from testing to targeted treatments.org, a global group of people trying to make precision medicine a reality for all those who need it. And I'd like to say a big thank you to Sarah and Emma from SBK Healthcare who hosted this week's webinars. And so Sarah's mentioned, if you have any questions, please pop them in the box and we'll get to them in our discussion. So it is now with great pleasure that I get to introduce Professor Penelope Schofield. She's a behavioural scientist with over 30 years experience conducting research in the field of psycho-oncology. And Professor Schofield has held numerous leadership roles which have informed research strategy, policy and service delivery to promote cancer control in Australia and internationally. Penelope has extensive experience in behavioural, psychosocial quality of life and supportive care research in cancer and other chronic illnesses, particularly in randomised controlled trials. She's also the principal investigator on the SuperNext trial, the aim of which is to improve the diagnosis, care and treatment of people with cancer of unknown primary. And we had her colleague, Professor Richard Tothill, speaking earlier in the week. So it's fantastic to see all this work going on in Australia. And one of the major goals of the SuperNext study is to help patients and the carers understand not only their disease, but also how new innovations in science and technology can help improve their diagnosis and treatment. So it's fantastic for all CUP patients. So thank you, Penelope.
Thank you very much. I'll just share my screen. And that's sharing okay, is it? Can I get a thumbs up? Okay, thank you very much for the organisers for inviting me to talk about this today. This is something cancer of unknown primary is something that I'm really passionate about. And I'd like to acknowledge the funders of this research and also my two key collaborators, Richard Tothill, who you heard from earlier this week, and Linda Malishkin. Now, the journey of being diagnosed and treated for cancer of unknown primary is arduous and complex illness trajectory. And for clinicians, the pathway looks something like this. However, we know that for patients and carers, it can feel something more like this: inescapable, frightening, and you're not sure where you're going to end up. I'd like just to talk about the origins of our SUPER program of research. So SUPER stands for Solving Unknown Primary Cancers. And it really started with Richard Tothill's PhD nearly 20 years ago with his supervisor, David Botel, and he was the first to show a clinical application of identifying the likely site of origin. Then Professor Linda Malishkin established Australia's first CUP clinic, and simultaneously that year, one of a very magnificent woman who was sadly passed now, Jane Barrett, actually buttonholed myself and David Botel at a conference and said, "You guys really need to get together and start a program of research on cancer of unknown primary." She was our first consumer advocate. A year later, we won our first grant to support the SUPER program of research. And at that time, we connected with John Simons, who has become a very good friend and a mentor of our program of research and helped us connect with the international community that I'm talking to today. In 2018, Cindy Bryant formed our Consumer CUP Committee. This Consumer Committee consists of 8 patients and also carers, and they direct, inform, and guide our program of research. So this is really the suite of research that we conduct, and it's basically we have cohort recruitment, and we collect biomedical samples, we collect clinical data, and what I'm going to talk to you today about is the psychosocial and quality life data that we collect through this program of research. So I'd like to acknowledge here my postdoctoral researcher, Lisa Guccione. This is a paper that she and I have very recently published, and it's looking at the psychological distress, quality of life, unmet needs, symptoms, uncertainty, and hopelessness reported by people diagnosed with cancer of unknown primary compared to those who are diagnosed with a metastatic disease of unknown primary. Both groups were diagnosed within 2 months. We also looked at the CUP sample in relation to quality of life measures compared to general population cancer, a cancer comparison group. So these are the measures that we looked at. We measured physical, social, and mental health outcomes, cancer-specific quality of life. We looked at medical communication and psychological needs, hopelessness, uncertainty, and communication about and understanding of illness and treatment. And those items were drawn from the Cancer Experiences survey that has been widely used in the UK, but adapted for Australian context. So this is the results summary. So in comparison to people with a metastatic disease where the primary site of the cancer is known, CUP patients were more likely to have needs in terms of medical communication and information which had not been met by the health service. More than half had reported not receiving any written information about their cancer, and were less likely to find their written cancer use, the written information useful. I should note that actually Linda, Richard and I have actually written the only Cancer of Unknown Primary information book for people with Cancer of Unknown Primary. And that's the only resource that we know of that's available in Australia. They were also less likely to find the online information about their cancer useful, and they did express much higher levels of uncertainty about their disease. But they did have equivalent quality of life and symptoms compared to those with people with cancer of a non-primary who had advanced disease. They also had much poorer quality of life than other cancer patients in general. So what were the conclusions from this paper? Firstly, there's been a real notable paucity of information resources for Cancer of Unknown Primary. There's a lack of provision to people who are diagnosed with CUP within health services, and this may contribute to the greater uncertainty experienced by patients. And this uncertainty is really the greatest identified psychological burden for people with CUP. So I'd like to now acknowledge my PhD student, Camille Walnick. He also actually happens to have a PhD in molecular biology, so he is ideally suited to doing this PhD. He was interested in the relationship between psychological distress, understanding of the cancer and illness uncertainty in people with CUP. And so this is the model that he tested. He wanted to look at the relationship between, to see if people with poorer understanding of their CUP experience greater feelings of psychological distress than those with better understanding. If this relationship between a person's understanding of their illness and their psychological distress is mediated by illness uncertainty. And what I mean by mediated is, does that relationship really transition through feelings of uncertainty, which then impacts on a person's psychological well-being? And then to look at whether a person's degree of understanding can be predicted by various clinical and socio-demographic factors. What we did find was that the model indeed supported that lower understanding was linked to higher psychological distress. And this was virtually entirely mediated by illness uncertainty, which means that the understanding then converted into a real uncertainty, a lack of understanding converted into a real illness uncertainty, which then impacted on their psychological well-being. The other thing that we found was that physical symptoms, so the higher amount of physical symptoms, particularly fatigue, pain, and sleeplessness, impacted directly on increased illness uncertainty and increased psychological distress. And younger age was the only predictor of lower understanding and higher psychological distress of the socio-demographic and clinical factors that we tested. So what are the conclusions? I think that we as health services really need to find ways to improve patients' understanding about their disease, to reduce that uncertainty, and that in turn will alleviate psychological distress. We need to offer more mental health support, particularly to younger patients. So what has been the big revolution in Cancer of Unknown Primary since I've been working in this field? And that's genomic analysis. So for people that are not familiar with this, what that means is that a sample of the tumour the cancer tumour is taken, and they extract the DNA. Then they look at aspects of the DNA and they compare those aspects of the DNA with a library of known primary tumours. And then they can say, this looks like a breast cancer, because the tumour will often remember the organ it came from. The other aspects are what's called somatic mutations. So these are mutations that occur in cancers. And so, for instance, a MET mutation actually can be treated quite successfully with the drug crizotinib. The other thing is that we look for is what's called a germline mutation. And these are mutations that are inherited, such as the BRCA1 mutation, which is associated with breast cancer. These can all be looked at together with clinical data, histopathological data, to provide indications of where the primary came from, where the cancer actually came from, so the primary site, and it can be indicative of what kinds of treatments may be more successful. But what we were interested in, and again, Camille did this research, and it's just been very recently published in Psycho-Oncology, looking at how do cancer patients in general understand genomic testing and what are their information needs. So we did a systematic review. What he found was 14 studies, 5 qualitative, 9 quantitative. And what he found was a considerable proportion of people lacked good understanding of genomics testing, which might lead to more focused treatments. And they wanted to be better informed. Low education, older age, low income, and unemployment were the factors associated with poor genomic testing knowledge. Most people preferred face-to-face communication with their oncologists to discuss and ask questions about genomic testing. And most wanted to receive simple, easy to understand written information about genomic testing. I think that really there is a lot of work to be done in this space. Genomic testing and the treatment implications are going to be increasingly important aspects of healthcare across cancers. Now, patients want to understand and be well informed about this, so that they can take part in treatment-making decisions about themselves. And we need to improve their knowledge and understanding. Now, this, I think, presents a real challenge for us, for the health professionals in the audience. Look, I don't know about you, but I'm a psychologist. I haven't done biology since year 10, and I actually had to go back to really learning about biology to really understand what these tests mean and how they can be used to direct treatment. Many people don't have that knowledge, and so I think that this is a real challenge for us in order to give people that sort of basic biological knowledge so that they can genuinely understand what these tests mean and be involved in that treatment-making decision process. I'm just going to finish up this talk by talking about our latest funded study, which is called SuperEd. And this is really solving unknown primary cancers to provide an earlier diagnosis. And we're going to be doing a stepped wedge cluster randomized control trial. And this is really to implement what we believe is a important and new model of care. These are my national collaborators. We've involved 20 healthcare services around about Australia. So what's the rationale? I mean, I think that I've really established the rationale. We really need to increase understanding, reduce uncertainty, improve psychological morbidity. How do we do this? We really need so there is also an urgent need for rapid access to Australian CUP expertise to improve time to diagnosis and optimise health outcomes. That's not just survival time, but that's also quality of life and psychological distress levels of uncertainty. This research really was guided and demanded by a consumer steering committee. We've had several workshops with them, and they have said to us they want CUP diagnosis times to be reduced so that people can enter into treatment earlier, and they need far better information and support tailored to their specific needs. CUP consumers also want a CUP coordinator to really help navigate the health system, which is very complex. And we know from work done in the UK that CUP patients tend to be bounced around the system from one service to another. So the aims of this study were to develop a new model of care, firstly, and secondly, to implement this new model of care. And really the endpoints are rapid, accurate diagnosis of either CUP or identifying a known metastatic primary, and that's our primary endpoint. Get greater access to clinical trials, and that means access to genomic testing. It is funded in other parts of the world, but it is not currently funded by the government in Australia. Improve experiential outcomes and reduce uncertainty and reduce healthcare costs. So what have we done so far? So far, we've had this funding for a year, and we have really worked very hard on developing all of these elements of the new model of care. So the idea is that we find that we identify patients who have been identified with a malignancy of undefined origin. So they have had minimal clinical workup, but on first pass, the primary cancer cannot be found. They would then be entered into the new model of care. This would involve a standardized best practice histopathological and clinical workup, which we have developed an SOP, standard operating procedure, and that will be implemented across the 20 hospitals. We will appoint local care CUP coordinators in each of these 20 hospitals with a defined model of work and defined expectations. We're also going to hold a virtual second opinion CUP multidisciplinary meeting, and that's drawing upon the CUP expertise that exists within Peter MacCallum Cancer Centre and that we have developed through the super program of research, working closely with our clinicians. So these are pathologists, imaging specialists, medical doctors, nurses, who all have specialist expertise in cancer of unknown primary. And the other thing that we're doing, and I'm heavily involved in, is we're developing an interactive website for CUP. This will be both to upskill clinicians in what are the latest research findings in relation to cancer of unknown primary around Australia. It will have a portal for clinicians and patients to access all recruiting trials for cancer of unknown primary around the country. And it will have a large section for patient information, which will be graded to how much information a person wants. People might want very straightforward dot point basic information, or they may also wish to read lay summaries of the latest research papers, so that will be provided to them. We will also be providing videos of people who have cancer of unknown primary and also carers, also clinicians who have got expertise in this area. And that all of this is coming to fruition probably by Christmas this year. We will implement this new model of care in a staged fashion across the 20 sites across Australia. And what we hypothesize is that when we implement this new model of care, we will reduce the time to diagnosis, we will improve patient-reported experiences and outcomes, hopefully reducing uncertainty and psychological morbidity. And for those people who, with that earlier diagnosis, we hope that that will mean rapid access to and entry into relevant clinical trials or CUP research. We also will be measuring rapid access to palliative care. And we will also measure these outcomes in people who have actually, through the process of diagnosis, have a primary tumour identified. So I'd just like to conclude here by saying that really those people who are affected by CUP, the patients and the carers and loved ones, need far more information and clinical support to help them understand their disease, the diagnostic options, the clinical trials that are open to them, and the treatment options to ameliorate uncertainty, psychological morbidity, and really promote hope in this domain. We know that clinicians need to be upskilled and need access to CUP expertise. There are some clinicians who are experts in CUP, but many oncologists really are not familiar with the latest evidence in cancer of unknown primary. They need upskilling in the new diagnostic modalities, particularly genomic testing, what clinical trials are available to them and their patients. The other thing that I would say, and this is my experience in working in the super program of research, is that I think that as researchers, we really need to have a concerted research effort that not only looks at molecular biology, genomic work, not only clinical trials, new treatment options, but also what is the experiential psychosocial impact on patients. And by this, in this way of working in a concerted effort where we're all sitting around the same table, that means that we are treating the patient, we're putting the patient at the very center of our efforts to address all of the needs simultaneously and maximize our use of the funding dollar. Thank you very much for listening to me.
Thank you, Penny. That was fantastic. It's so interesting. And I look forward to discussion now shortly. In the meantime, I'll just introduce Alison Taylor. Alison Taylor is a nurse consultant at the Clatterbridge Cancer Centre, where she's the lead for acute oncology and cancer of unknown primary. Alison trained at the University of Liverpool and specialised in cancer care. She's had a variety of roles over her 20-year career, with her most recent roles including acute oncology and cancer of unknown primary clinical nurse specialist at the Countess of Chester Hospital, where she also seconded as the clinical expert and module leader for the University of Liverpool online acute oncology course. She completed her Florence Nightingale Foundation Emerging Leaders Scholarship in 2020, and she's passionate about leading cancer care and moved back to Clatterbridge Cancer Centre as the nurse consultant, where she has a vision to continue to raise awareness of CUP and provide equity of services for patients with CUP. And she's also led the development of optimal pathways for the malignancy of unknown origin and reformed the CUP service for Cheshire and Merseyside. She's also the Associate Principal Investigator for the CUP-COMP genomic trial at Clatterbridge Cancer Centre. Thank you so much, Alison, for joining us.
Thank you, Tanya. Wow, that was a great introduction. Makes me sound brilliant. We have done a lot of work.
But it just shows you how much one person can do in the area and how you can drive exactly what the services that we need. And I suppose a nurse consultant post is unusual, especially in Ireland. So I'm sure you wouldn't mind telling us a bit more about your position and the work you do in the Clatterbridge.
Yeah, so the Clatteridge Cancer Centre is a regional cancer centre in the northwest of England, and so we cover quite a big geographical area, and we've reformed a lot of our services over the last couple of years to create a specialist cancer of unknown primary team, because we could see the need for this patient group. And a lot of our care was excellent care, but it was ad hoc in little pockets. So it was very, very small teams looking after these patients. That we've sort of reinvigorated the services across our region. And we've got a specialist team of cancer unknown primary experts at the Clatteridge Cancer Centre. So we have 2 oncologists, myself as the nurse consultant. We're really lucky to have a clinical support worker as well, which is a really, really key role for supporting patients. We have a regional specialist multidisciplinary team meeting every week, which is where teams from the region, the local teams, can feed in complex cases that might be malignancy of unknown origin for advice and guidance on specialist investigations, tests, biopsies, but also for those patients that are confirmed as cancer of unknown primary, where we discuss their imaging, their care, and what treatment we can provide. So we have a really good team of expert pathologists and radiologists, and they're a key part of our team to getting the answer quickly. Penelope mentioned this in her presentation, but often these patients have a very long journey getting to us in the specialist services. So we've done another big piece of work over the last 12-18 months at trying to improve the front end of the pathway, the part that we would call the malignancy of unknown origin, in the local teams, so that patients are getting to the local teams quickly and then passed on to us in the specialist teams across the region. We've also set up this year the CUP-COMP trial, which is a genomic study. I've been really lucky to be the associate PI on that study. And again, we've had relatively small numbers of patients that have been eligible to access the trial, but it is showing that we're finding genomic mutations in patients, which is opening up another role in different treatments that we can provide. So it's really exciting.
That's fantastic. And I think as well, to have you at the centre of it, that you know the trials that are happening, that you can coordinate the patients to them is also another benefit of having these CUP coordinators. Is I think that's exactly what the patients are missing. They've no link to bring them. And like you talk about, Penelope, the MDT tennis, where they're sent from one specialty to the other, and it's all time delays and of course adding to the uncertainty. So I suppose when you do meet the patients, how do they find their diagnosis? How are they feeling when they come to that time of diagnosis?
Yeah, like you said, it can have been a very long pathway. Hopefully it hasn't been, with some of the improvements we've put in place. But I think when they get to us at the cancer centre, they're scared. They're often still don't understand the details. They know they've got a metastatic cancer. Sometimes it hasn't been explained very well by other teams of what that means and how we can treat it. They're often quite still in shock, really, that how can you have a cancer where you don't know where it's come from? We hear that a lot, particularly with all our modern technology and scans, and often they've had multiple biopsies. So there's that feeling of why can't you find where the cancer has started? But then there's also the hope that they've made it to the cancer centre, and what's the treatment plan? What can we do to make things better? So it's mixed, really.
I think that's something we found too. You know, when you're given a kind of a rare, and like, I wouldn't necessarily say it's rare, but when you get a diagnosis that there's not so much known about, it's that loneliness. And as Penelope said, the education and the information isn't there. So where do you turn to? And like you just don't belong. And I think that's the fantastic thing about having CUP pathways, having CUP organizations, is that you mightn't necessarily know where the primary comes, but you know all about CUP. And I suppose it's trying to say to patients, we know what it is, you know, and there's so much going on around it. So like, even how all this uncertainty must impact the patient, Penelope, how does that affect them, the uncertainty, from a psychological point of view?
I mean, I think that the uncertainty really, as Camille's work actually showed, the uncertainty is really driving a lot of the psychological distress. And as you say, I mean, there's a lot of confusion. Well, why can't you find the cancer? Is it that my doctor and my treatment team isn't good enough, that they're just not, either that they, you know, are failing somehow? And I think also because there has been such little awareness of cancer of unknown primary, very few people have heard of it outside of oncology circles. So then you get your friends and your family saying, well, what do you mean they can't find it? Of course, you need another doctor. And so I think that just adds to the entire uncertainty. And I guess that this is where I feel very strongly that we need to be able to provide patients with access to genomic testing, because like Alison, many other places, certainly in the US, so Greco and Netherlands, I can't remember the group in Netherlands, they're doing they're doing excellent work on genomic testing. And I'll just share one little brief story with you, is that we had a gentleman in our trial. He was very, very ill, really unwell, and it was December. All he wanted to do was make it to Christmas Day with his family. But we rushed the genomic testing through. It came back likely site of origin with a 90% match, kidney cancer. Linda Malishkin, who was his oncologist, gave him kidney cancer, you know, so chemotherapy for metastatic kidney cancer. And that man lived to see 3-4 more Christmases. And it is a real story of hope. And I think that this is what we need to emphasize more, I think, with our patients, is that, look, we are making huge advances. And yes, it can feel very, you know, frightening and uncertain, but really there are options here, and we can, I think, provide some hope for our patients now.
No, exactly. And I suppose even how do you build that hope? And I suppose it goes back to the information. As you said, Penelope, you had to write the CUP information booklet for Australia. That was the same here in Ireland. I searched and searched for some information, and we had to write it ourselves too. And I think that's, you know, when you leave an appointment, you need to have some backup information, to have some education. And it's so interesting to see Dr. Camille's research and how that improves the patient's understanding and reaction to treatment. Because also with all this psychological distress of uncertainty and this phenomenon of this intolerance of uncertainty, can you explain what that is for patients?
Well, I think there's a very natural intolerance for uncertainty. I mean, we've all been through the pandemic, through a very uncertain time. And I think that human beings just naturally don't like uncertainty. And unfortunately, probably cancer of unknown primary is the cancer that has the greatest level of uncertainty in terms of, you know, how long are people going to survive? You know, are the treatments going to be effective? You know, where is the cancer? And I think that really can play upon people's minds. I mean, I think, yeah. But going back to the information, I mean, I noticed in the chat that one of the people said Macmillan had a book. Now, I'm huge respect for Macmillan and their information. I think that the real issue is it actually needs to be country specific, because all of our so there are different cultural requirements, and also there are different health systems. So our health system in Australia is quite different to the NHS, for instance, in the UK. So I think that it does need to be very much tailored to the local environment. But the other thing is that I can really, I'm really thinking about a lot more, is that it also needs to be tailored to an individual's personal requirements. So, you know, you have people who want kind of very basic information. That's what they want. And they want the doctor to take a lot of decisional control. Then you have people on the other end of the spectrum who want to actually understand what is the latest research evidence saying, and they want to have far more decisional control over what actually is occurring. And I think that actually once people can gain some sense of control over their illness and what's happening to their body, that then actually helps reduce that uncertainty and that psychological distress.
That's true. Do you find that in practice, Alison, with your patients?
Yeah, I would totally mirror that. And I think cancer of unknown primary is, although we're calling it it's like a generic term, everybody's cancer is different. It's not like a breast cancer where you have the same stage, you have the same drugs. It is a terminology for multiple different cancers. So everybody's needs are different. So one thing we try to do in our team, and it's quite common practice in cancer teams in the UK, is a holistic needs assessment. So we do an assessment at diagnosis. After the patient's left our first clinical appointment, we contact them after that so they can digest some of the information that we've given, both verbally and written. And we ask questions about what's worrying them, what's important to them. So not what we assume. So we look at the physical symptoms, their emotional symptoms, psychological, financial, and ask a really wide series of questions to the patients to what's important for them and what we can do to support them going forward. So sometimes, like Penelope said, we've got a variety of people that some people want every detail. I've got a patient who's an engineer and he wants to know the detail of everything, every scan, every test. But then I've got other patients that just say, right, well, I'll do whatever you tell me to do. Give me the very basics. I don't need to know the ins and outs of every test. I trust you. So it's very personalised what everybody needs, and the family and carers may need something very different to the patients. So I think that there's two sets of information that we need. We need it for the patients to understand so they can make the decisions, but then also to support the patients and the families and carers that are supporting them as well. But I think it's very personalised. We have both. We use the Macmillan information, which is excellent. It is quite generic. We've got some specific information for patients at the beginning of the pathway in that malignancy of unknown origin phase, because we're hoping we will find a primary at that point, and that's very different from a diagnosis of cancer of unknown primary. Again, like you said, a lot of patients use the internet resources, and there isn't a lot out there. There's some excellent stuff on the charities mentioned today. So we do try to signpost patients if they are going to use internet resources into that sort of forums. But then also we have some local information that like Penelope was saying, that's very specific to our hospital and the services that we can offer that are from our hospital. So we are very lucky that we've got an excellent team around us as well. So we've got an excellent palliative care team, we've got excellent psychologists, we've got access to holistic therapies and treatments. So it's very personalised. Some people would not want to engage with the holistic therapies, but others really love it. So it's very, very personalised. And I think that's probably the key thing that comes out with working with this group of patients. No two patients are the same. No two patients' information needs are the same. And we have to work with them. And probably the biggest thing from our team is we're the key workers. They've got our contact details. They can ask us any questions that they want to. And we're accessible. They can contact us. If they don't just have to wait for their clinic appointments, they can contact us and ask those questions. We encourage patients to write questions down to bring back with them. No such thing as a silly question. If that's what's worrying them, we need to be able to answer that. But often a bigger part of our role is just listening to patients' concerns, listening to what they want, and then signposting to the other support services or information that we can help them with.
Like, it's so true, because I suppose the anxiety levels and the mental health issues, for patients dealing with this uncertainty, like how can they cope with it? How do you find your patients can help with coping mechanisms to deal with the diagnosis?
Again, I think everybody's different. Some people have coped and used mechanisms that they've had to cope with other things in the past. Other people really struggle to cope. And again, that's where they need the support from our team to be there and to help them along the way. It is very difficult, and living with uncertainty is very hard. And I think particularly in CUP patients, because even when we get a little bit of hope and we start patients on treatment, there'll be another scan coming. So there's uncertainty with that. And even though the treatment might be successful, it's then how long would the treatment last? That we build all these levels of uncertainty on top of each other, and it seems never ending. Even when patients are stable, this group of patients often have a relatively poor prognosis. So when patients are doing really well, that should be a positive, but I know patients see that as often, well, I'm well at the moment, but how long will it last? So it's very, very difficult. And I think it's just having that key team of people that they can come to with anything, listening and supporting them however we can. And I think Penelope's work touched on that as well. It's having that key contact that they know, they trust. And if we don't have the answers, we will try and find out. And sometimes we don't have any of the answers. And I think sometimes just sharing the uncertainty with the patient, and if we're expecting a result, it's disappointing for us as the healthcare providers as well, if we can't answer the questions or we don't get the answer that we were expecting in a test or a biopsy. So sometimes we do have to share some of that and that empathy with the patients and the carers as well, but it can be very difficult.
I suppose, trying to build resilience is something, I suppose, that can help. Penelope, do you have any comments on how to build resilience and how you can kind of focus on that, or is it very difficult?
I mean, I think that I go back to, I guess, helping people. Well, first of all, information. I think that most people need that sort of information, and people's information needs, as we've talked about, will vary. I think information is really important. The second thing I would also say is getting the entire family on the same page. And, I've actually also done work with actually some colleagues in Belfast who have done a fantastic, I think it's called the Cancer Coping and Caring website. So, and I think that Alison's very right that the carers need actually quite different information. And it's about, well, what's this trajectory going to look like, and how can I plan for that, and what skills am I going to need? And so I think that information, building those skills, having the family all on the same page. And I also think there's wonderful therapy that actually has been done with Gary Roden in Canada on dignity therapy and meaning-based therapy. And I often think when people do have a disease that probably isn't curable, as most cancer of unknown primaries are not curable. The head and neck ones can be curable, but most of them are not curable. That it's actually, deriving that sense of meaning in their life. And so that all of these things, it's understanding, building those sort of behavioural coping sorts of strategies, but also, if you like, having a sort of a meaning-based, and for some people that might be a spirituality, for other people they base their meaning in other things, having lived a good life, having contributed to the world well. And so I think that this is also where, for me, it's, in order to deal with the real psychosocial and issues that are faced by people and the families that are affected by cancer of unknown primary, it's really important not only to do all the work that's, the diagnosis, trying to find indications about what are the most appropriate treatments, targeting those treatments to the individual, providing them with that information, but also alongside doing that sort of palliative care work, making sure their symptoms are controlled well, because we know that symptoms impact on a patient's uncertainty, also independently impact on their psychological morbidity. But part of that palliative care work is actually making sense in a sort of a meaning-based way of what does my diagnosis mean? What's important to me in life? What do I derive meaning from? And so
Sorry to disrupt you. Sorry, we had a slide. Emma, if you wouldn't mind showing the slide on the palliative care slide. It's just, sorry, as Penelope, sorry to interrupt you there, but I just came across this slide. It was Palliative Care Week last week. And I suppose what I would love for palliative care to have a total rebrand, because patients are so terrified of it or using it because they think it's end of life. But what actual palliative care means is exactly what you said. All this support by experts. You know, the palliative care team are the experts in all aspects of social care, community involvement, you know, the holistic approach, and especially symptom control. I think it's the burden of symptoms with patients and just trying to get a proper control on these symptoms, both spiritually and physically. Whereas if we have early access to palliative care, and not to be afraid of palliative care, to see it more as a symptom and support, as opposed to, you know, a death sentence, because it doesn't necessarily mean you're dying. It just means you're going to get this proper holistic care.
And I think that for most people with cancer of unknown primary, it's really important that they are referred to palliative care early. And this is one of the aspects of the model of care that we hope to implement. And one of the end points is that, because there has been actually lovely research done in the US, and it's now been replicated in Australia, to show that if people who, once they're diagnosed with metastatic disease, if they are referred to palliative care early early after that diagnosis of metastatic disease, they actually survive longer and have much better quality of life. And it is actually about coming to terms with all of these aspects. I also think that it's invaluable for carers to really build up their skill base, and it takes away, I think, really the fear of that unknown, and also it can ameliorate some of the uncertainty if you know what to do, if the patient and the family know what to do, how to control the fatigue, how to control the pain, control nausea, these sorts of things. It gives people much more control over what can seem like an out of control situation.
And Alison, would you involve palliative care early in the patient?
Yeah, I was going to say, building on a conversation we have very early with our patients on our first meeting, really, in our clinics, is around quality of life and what's important to the patient. And sometimes treatment isn't what's going to provide the best quality of life for patients. So we have this conversation very, very early. We're lucky we've got excellent palliative care support from our colleagues within the organisation. And there's been a big focus in our organisation on palliative care being around symptom management, but actually we're moving forwards from that. So we refer in, which is kind of the stepping stone to palliative care, called enhanced supportive care. So it's branded a little bit more differently, but again, it's going to that holistic approach. So they can provide symptom support, but it's also the psychological, the emotional support, spiritual. So that is part of our treatment plan. Palliative care support is part of that. Whatever our other treatments may be, that's definitely part of our first conversations. And some of our patients, because we've improved the regional pathways, are very, very well stitched in with the palliative care teams. Again, I think it's explaining things in a clear way, because I think once you start to talk about symptom control, if a patient presents very symptomatic, that's one of the things that's on their list of questions. They want to know how we're going to help improve their symptoms. And sometimes we need to do that with the palliative care team support before we can move on and give any other types of treatments. So we are really looking, that is definitely part of our team approach. Again, it's getting the families on board as well, and the more that we can talk about what palliative care is and what it isn't, then I think getting the families to understand the rationale as well, because I think sometimes people think that when we start to use those words around palliative and is it that we've given up and we're not going to provide any treatment, but it is part of our treatment plan, and it's just the terminology and making people understand the rationale behind why we want to involve these extra teams.
I better just get some questions here now. We're nearly out of time. There's a question here. How is the cooperation in the medical team, this is for Penelope, that surrounds the patient functioning in Australia at this moment? Penelope talks about upscaling oncologists. Is there also a program on training nurses?
Thank you for the question. In most of our major treatment centres, probably not the very small rural centres. Cancer patients will receive treatment from a multidisciplinary team. I don't think that this is the case for cancer of unknown primary necessarily. I think there's still a certain amount of bouncing around between teams. It does occur in major treatment centres now in Melbourne and Sydney, maybe in Brisbane. In terms of upskilling nurses, we do not regularly have CUP care coordinators like there is in the UK. But this is where the program of research that I'm doing at the moment, we will be having CUP care coordinators. I imagine that they're going to be nurses. And they will certainly be rigorously upskilled in cancer of unknown primary. And part of their role will be to be the site champion. So really to champion, upskilling all clinicians and raising awareness about cancer of unknown primary. Part of the website is the Clinician's Corner. Now, it will be for oncologists, but it will also be for all clinicians, so doctors, nurses, allied health. And we're certainly, and in fact, we're doing this filming at the moment. We're filming, I guess, a representative from all of these sorts of clinical craft groups who are skilled in managing people who have got cancer of unknown primary. I do think, though, we've got a long way to go, and we're certainly behind the UK in terms of, I think, upskilling clinicians. And I'm not sure about, I'm familiar with what goes on in the UK, but I'm not familiar about what goes on so much in the US or Europe or other places around the world.
Very good. That's a great idea to start. Anyway, hopefully we can spread it around the world. Another question for Alison. How is the expert centre connecting with the specialist services? There is a lot of knowledge in the specialist teams. So what role is the centre taking?
So I think we're quite lucky in our region that we link quite closely with the smaller organisations within the region. So we do a lot of work across our geographical region with education and study days and things like that. But I think we've got a much bigger role to play. A bit like Penelope was just saying, I love the idea of the Super Ed sort of portal where we can sort of have that links between clinicians so that we know when we work very closely with our sort of next region, which is Greater Manchester, because they've got an excellent CUP team in Manchester, but we are getting better at linking up across the nation. We're still very niche, very small teams that have just got a passion and see that there's a lot of inequity in the system. So I think Penelope said it, we've got a long way to go, but we are trying to spread the word and to get people to understand. And I think events like this, international events, are absolutely brilliant just to raise that awareness of what cancer of unknown primary is. And I think we've got a lot of resource in very small niche places that we can share regionally, nationally and internationally. And I think that's what, as a CUP community, we've got to do to improve things going forwards.
I think I have a great question just to finish up this session with for you both. What will still be necessary in order to get the psychological support for patients as part of their standard of care or budget, as it seems that in many countries this type of support for patients is considered important, but it is not yet standard of care?
Yeah, I think that's a difficult one, and I think it's the same for a lot of other cancers as well. I think in some countries that you can see the need, but the services aren't there. We need to invest in those services for everybody, and cancer of unknown primary patients are key to accessing that service. I know we're very lucky in our country, in our region, that we've started to push forwards with some of this work, but I know it's not equitable around the globe.
So this is something that I think about a great deal, Tanya, because for instance, if you come to Peter MacCallum Cancer Centre, which is in the centre of Melbourne, we have an entire psychology department, and if you're very distressed, you get to see psychologist for several sessions for free. If you live in remote, far northwest Queensland, you don't get to see a psychologist. And while we do have some, government support, it's still a co-payment system. So, and a lot of people can't afford a co-payment type of system. I guess that, and this moves on to one of my other, hobby horses, is I think that really what we've got to do, because valuable resources like Alison, are expensive, and we can't necessarily provide 12 sessions with a psychologist for everyone. And I think that this is where we have to start looking at intelligently layering targeted clinician support with digital platforms and solutions. So there's a lot we can do, I think, through digital programs, linking people in, online support communities, and then using our expensive face-to-face one-on-one clinicians for the people who really, really most need it.
I think that's a fantastic way to end the session. It's definitely something that we could all look into in the future. Thank you so much, Penelope, and thank you, Alison.
Thank you.